All right, good afternoon. Welcome back, the intrepid after lunch. It's my great pleasure to introduce Dr. Ramin Khorasani from Brigham Women's Hospital and Harvard Medical School. He's a professor of radiology and chair of medical informatics. So he kicks us off in this session, which again, this is session 2B, developing and supporting a workforce for high-quality oncology diagnosis and care, role of decision support guidelines and appropriate use criteria. And he's going to be speaking about oncologic imaging, clinical decision support technologies for oncologic imaging. Ramin.
Thank you. Good afternoon. I wanted to thank Dr. Risak and the committee for planning and this fabulous workshop. And it's a distinct pleasure to be here and quite an honor to speak in front of all of you. Just a couple of disclosures to put up. Those are my current active disclosures. And just for completeness, these are some of the prior inactive disclosures. The topics that I will cover today, I'll go through a very quick background. We'll talk about what clinical decision support is. I will review some of the federal laws and regulations actually about imaging CDS, clinical decision support, which I will refer to as CDS. So you'll hear me repeat that acronym, CDS standing for clinical decision support. I will speak about implementation challenges and opportunities, and hopefully make a case for broad collaboration and propose a potential framework for collaboration. I'll finish with patient engagement and a few take-home messages. This is one of my favorite publications ever. This is the 2001 Crossing the Quality Chasm report from the Institute of Medicine, which defined attributes of high-quality healthcare and clearly highlighted is practice that is based on evidence or best practices where evidence does not exist. In that background, we also know that discovery will continue to excite and inspire us to do great things and to discover new things. And by the way, as a little bit of a disclosure, I was asked to be provocative. So I'm going to try to be provocative in these set of slides and get a discussion point going. So you'll see some of the slides use some strong language to get us thinking about some possibilities. So if you think about most of our major academic centers and major healthcare organizations that think about discovery as the core of their mission, however, our major challenge in healthcare is actually a failure of execution. And I'm quoting a colleague that I collaborate with, Atul Gawande, and to put that in a sentence where we are hurting in healthcare is that what we really need to do, if you like, is do what we know works for patients and do that consistently. So let's see if we can highlight that and describe that a little more. How do we know what is it that we do know? What is the current state of evidence? What is the knowledge base that we have today? Where are the guidelines, best practices, decision rules? How does a provider find them? How does a patient find them? Are they trustworthy? Are they worth changing our decisions on? How long does it take to adopt new evidence into practice? So if a fabulous article gets published today in New England Journal of Medicine or the like, it will take 5 to 14 years before that evidence gets into practice. And when it is, it will be heterogeneous in its adoption. And you as a patient will have no idea whether the physician in front of you is actually following that evidence or not, because there is no way to judge that in those personal interactions. Do our systems promote the right care? Working harder and smarter is not the answer. Another IOM report. And is the right care embedded in your workflow? If you are a physician seeing a patient for your 14-minute follow-up, do you have enough time to go and log in to a library website, pull an article, and read it? How do we know how we are doing and how we can improve what our work is. To manage the change in the current state, to manage behaviors of people, we need to be able to measure performance, and we need to be able to assess whether our practitioners are adhering to evidence to reduce unwarranted variations in care. So are there unwarranted variations in care for diagnostic imaging? This is published in Radiology. This is a heat map of high-cost imaging across the United States using Medicare data, payments to physicians, and the number of beneficiaries in one of 600 health referral regions. And the reds are the areas where there is high utilization per Medicare beneficiary and high payment. And as you can see, they are not happening just in major academic centers. They're in some odd locations that may not be so odd. But from a public health perspective, when you see a graph like this, it is hard to imagine that you can have an intervention, a one-size intervention, that fits all across this map. So the challenge is pretty obvious. Now, one may think there is national variation. Are there local variations? And as a person who's involved in quality improvement, one of the most important things you learn is you embarrass yourself often when you speak to colleagues. And this is data from my own institution. And this is variation in follow-up imaging recommendations our faculty make in one of our divisions, controlled after controlling for how many years they've been in practice, how many cases read, what modality they read. We've controlled for everything we know, and there's still almost a threefold difference between physician number 1 and physician number 12. If you were a patient and you showed up to our practice, you will get a chance 1/3 likelihood if Dr. X is reading versus Dr. Y. Should we disclose that to our patients when you arrive, that today Dr. X is reading and there is a 3 times more likelihood of a follow-up recommendation? Would you like to come back tomorrow because Dr. X is reading and they're doing less? So one of the things that you learn when we do this work is that sometimes, it's surprising, but it's true, that variations even in single institutions sometimes is larger than variations among institutions, which is a very jarring task to take on. So what is clinical decision support and why is it important? The essence of decision support is to reduce and go address these unwarranted variations. And what you're dealing with is an expert system to improve performance of a non-expert clinician. That is to say, a physician with a computer, an average physician with a computer, is going to behave like an expert clinician. That has been the vision of computers in medicine for 40 years. And we have a long, long way to go before we can make that happen. So the goal is reduce unwarranted variation in care and adhere to what we know benefits patients. I hope that makes sense. So examples of clinical decision support for imaging, whether it's at the time an examination is requested, when a physician is using a computer to request an exam, the goal there is to reduce unnecessary testing, to reduce cost and waste, but more importantly is to impact the experience of care for a patient. If you go to a car dealership and you get a service on your car that wasn't necessary, you get angry. Imagine if you were a patient and you got an unnecessary test, and that test resulted in a whole bunch of downstream unnecessary diagnostic or therapeutic interventions. So we have a long way ahead of us. Whether it's also same tools can be presented at the time of image interpretation using computer-aided detection and diagnosis to improve the accuracy of a radiologist interpretation, or at the time of reporting for a radiologist to improve the quality of recommendations for additional imaging, for example. They're broad. But the rules are actually fairly similar. That effective imaging CDS, those clinical decision support tools, there are the 5 E's. They have to be efficient. That means they have to be embedded in our workflow, and they have to not require a lot of redundant data entry. They have to be able to educate physicians or providers, and they have to be based on evidence. They've got to be brief actionable, and unambiguous, and they have to be able to provide evidence from whatever source there exists. And the source and the strength of evidence that is in that recommendation must be transparent to the user, and we must reduce and minimize low-value alerts. If we train you to click ignore, because we're showing you low-value alerts, you are going to click ignore even when we show you valuable things. The last is the 2 E's are encourage and enforce adoption of evidence. And that is important for me to remember to tell you, is that I have not yet met an IT intervention that actually improved the behavior of physicians without other quality improvement facets, tools that have consequences for ignoring that evidence. When you have 12 minutes to see a patient, the easiest thing you can do when a computer tells you to do something is that 2 seconds that it takes to click ignore. And that's oftentimes what many of our providers do in their very, very challenging workflow environment. Have these tools impacted imaging? And I thought I'd just use a couple of examples from the Choosing Wisely campaign. And there are several examples, and I will make sure they're attached to the proceedings of this meeting with actual references that you can read. But we have had some fairly significant impact in targeted and in many interventions across many of our high quality and sort of bleeding edge institutions. But they haven't really been replicated broadly across the country quite yet. I want to highlight the reduction in the use of lumbar spine MR on the day of low back pain visits to primary care. 30% reduction in the use of MR, which is actually the highest paid service by CMS for MR across the country. So what are the federal laws and regulations in imaging support, decision support? And this may be a surprise to many of you in this room. The law called PAMA, Protecting Access to Medicare Act, was passed in 2014, and its section 218B actually is targeted to promote evidence-based care, beginning with imaging, and the hope is that CMS will expand that over time to other clinical specialties. And the goal is to improve quality of care and reduce waste and embed tools in provider workflow to avoid very disruptive pre-authorization, if you like, interventions that many of our payers have instituted in their funding, if you like, interventions, and integrating these tools into the EHR. Now, you may be surprised to learn that beginning January of 2020, ordering professionals must be exposed to clinical decision support, and I'll get into some of the detail, when they order exams, or the radiologist who perform these exams will not be paid. It's an all or none alternative. It's not one of those carrot situations. You either get paid or not, and those targeted instruction, and I'll talk to you a little bit about what domains are covered. But the goal here is expose physicians to AUCs, appropriate use criteria, which are evidence-based criteria linking a clinical condition to an imaging service based on an assessment of appropriateness. So what does that look like? CMS has actually articulated that CMS will certify the syringe, the IT component that is built by payers, by vendors, and actually CMS is delegating the, if you like, the definition of the rules that are going to be embedded in these systems to organizations that are called qualified provider-led entities. And these regulations either, if you like, promote competition amongst vendors, or they can actually promote collaboration around organizations who are publishers of these rules. These are the clinical priority areas that CMS is requiring for January 2020. And you can see that cancer of the lung is directly related to cancer imaging, as well as suspected pulmonary embolism, because patients with cancer are at high risk of having pulmonary embolism or PE. But you can see the other topics that are going to be covered. These are publishers of those guidelines or rules that have been approved by CMS as of last July. And I highlighted two organizations that are only focused on cancer. And you can see Memorial Sloan Kettering and National Comprehensive Cancer Network are two organizations that are approved publishers of these rules that everybody has to use to meet the requirements for this law. So the big picture of this law is that the financial burden is with the radiologist and technical providers of imaging services, but the workflow burden is with the ordering providers. Not quite an aligned incentive, you might say. Pretty challenging environment, right? So let's talk a few minutes about what are the important elements of successful implementation of these tools. And I would like to sort of highlight clinical relevance and simplicity, and simply ask the question, are the health IT systems in 2018 optimized or at least capable to deliver evidence to improve physicians' decision-making? The promise of health IT 20 years ago. Are they ready? So, by the way, I get to show a lot of embarrassing slides that colleagues sent me. For those of you who can read it, this is a computer order in one of our major academic centers in North America for a head CT. And the request said, wrong place, wrong time. As a physician, I can't tell whether this patient was slapped or shot. And I can promise you there is no intelligent computer system, whether Dr. Langlotz thinks of it tomorrow or next year, that can solve this. If that is the information is coming across, it cannot be addressed. In 2018, our health IT systems have replaced that black screen with a fancier screen, but it's still with the same functionality. That you get to write what you want, but some institutions and organizations have thought, what if we got physicians and providers to choose the reason for exam from a menu, a structured menu? But you can imagine there are thousands of these indications, and a single indication does not represent why a test is done. If a colleague calls me and says, I have a patient with abdominal pain, is it the right test? My next question is, what kind of pain? How long have you had pain? Do they have any other clinical conditions? You cannot answer the question. So what happens is, if you try to answer this question by, here's an example in oncology, the structured indication with breast cancer, stage 2 or higher, but unfortunately the physician in their free text entry, because this wasn't available to them as a structure, they put in questionable metastases, the computer is going to give them the wrong answer because the computer could not consume that free text information. Here's where we're going to need help to consume the information existing in our records to be able to provide relevant information to physicians. Here are the 8 parameters you need if you want to decide, if you want the computer to be able to tell you if the order for a chest CT to assess for clot in the lungs is appropriate or not. It's a very high quality decision rule. You need these 8 clinical inputs. That is not available in our health IT systems without getting physicians to click, click, click. Makes it a real challenge. So in 2018, the realities that we have are that the goals of CDS need to be balanced against what is now called a public health crisis. And this is physician burnout, and this is a health affairs blog by some of the leaders of our major academic institutions in this country that you can read it for yourself. Technology, EHRs, is a major driver of burnout. Interruptions, distractions, and inefficiencies, federal regulations, performance measures are not helping not only they're not helping our physicians make better decisions, they're getting in the way our physicians taking care of their patients, which is the challenge of where we are from a technology framework. And then the other part of this is, do interventions that we aim to deliver through these tools, do they give us the results we want? And the results are mixed. We do have some interventions that, when combined with multidisciplinary, multifaceted interventions, have reduced unnecessary imaging, but IT interventions alone have not worked. So we have a major challenge ahead of us. So again, to wrap up here with a couple of concepts, is that discovery is crucial to future of medicine, but for the growing knowledge base and to address the failure of execution, we need a public domain repository of objectively graded health IT consumable evidence to help us move forward. If you can buy your songs in an iTunes library, why can't you find your evidence in an evidence library? And I'm going to show you an example of such a library that could be used as a framework for collaboration. And this is some of the work we've been doing at Harvard Medical School Library. And basically what this is, it's a resource for the public good. How it's designed, it's not publisher of a guideline, it's not a vendor of decision support systems. It essentially does not develop any new guidelines. It just curates what's out there in a consumable fashion so people and systems can access them. And it's a resource to accelerate AUC development and may serve as a framework for collaboration. And it's a long process, but let me just show you what it looks like. We use a grading system to grade the evidence. So if you wanted to have if you like, compare the information from professional society A to B, you could use a standard measure of quality to compare it, and that's Oxford Center for Evidence-Based Medicine's guidelines. And basically, it works like this. We have decision rules, professional society guidelines, and local best practices. Lots of rules. This just shows a nice little graph of things moving up. But what it looks like is, by the way, any of you can do this. You can Google Harvard Medical School Library of Evidence, get a login, and look to see what's there. And those, and I don't know if I can actually show it, but those gray bars, as opposed to showing you how popular a song is, those gray bars show you how strong the evidence behind the recommendation is. So you can judge whether you want it, and you can click on those boxes, take the evidence, and do what you may in your practice to make things better. So to wrap up, I do want to say that engaging patients in this context is really important, that we need to have patients engaged in making these recommendations applicable to the care of those patients, because not everybody prefers the same treatment, and their preferences are not embedded in our guidelines and rules to date. And that our take-home message for today is that suboptimal implementation and varied adoption of best practices leads to failure of execution of what we already know. And to do that consistently is a major challenge in transforming healthcare today. It diminishes, this current state diminishes the impact of any new discovery. Anything we do with AI, anything we do with precision medicine, can we get that to our patients? Or are these just great research projects? And that the current state of health IT is a significant challenge and a barrier for optimal implementation. And finally, that optimal, multifaceted clinical decision support enabled improvement initiatives will be needed to close the adoption gap and best practices. And collaboration would be a real welcome thing, particularly for those publishers of AUCs. Thank you very much. I'm a minute over, but it was close. Thank you.